Welcome everyone to session 201, discussion about thyroid nodules and pathological diagnosis and types of thyroid tumors and pathological features. It is my true pleasure to introduce Dr. Yuri Nikiforov. Dr. Nikiforov is Vice Chair for Molecular Pathology and the Director of the Division of Molecular and Genomic Pathology at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. Dr. Nikiforov oversees the operations of the Molecular and Genomic Pathology Laboratory in the clinical lab building. His clinical expertise is in surgical pathology of the thyroid gland and in molecular testing of thyroid tumors. Dr. Nikiforov is a ThyCa medical advisor. Dr. Nikiforov, welcome, and I'll turn it over to you.
Very much, Daria, for your kind introduction, and hello, everyone. What I thought that we'll do today, I just have a couple of very general introductory slides just to initiate the discussion of the histologic features or histologic types of thyroid tumors and molecular testing. I don't know, maybe a little bit of cytology we'll talk. And at that point, I planning to stop and open floor for discussion. And I'm sure that some of you have specific questions that we would focus on that. With that, so I want to say that generally, when we are talking about pathology of thyroid tumors, we follow the International World Health Organization classification of thyroid tumors and thyroid cancer. And this is just a general scheme, more like a historic that we had probably before 2017. We all know that most of thyroid cancers, they originate from so-called follicular thyroid cell. This is the main cell of thyroid. About 97% of all thyroid cells are follicular cells. And then minority are C cells. And C cells or parafollicular cells, they give rise to medullary carcinoma, medullary thyroid carcinoma. About 2% of all thyroid cancers are medullary carcinoma. And then follicular cells give rise to main type of thyroid cancer. Papillary carcinoma, which is the most common type, follicular carcinoma, about 5%. And then all of them are considered to be well-differentiated cancer. Then there is, unfortunately, a small proportion of tumors that undergo dedifferentiation and give rise to poorly differentiated and then to anaplastic carcinoma. So what happened in the fourth edition of WHO classification in 2017? Follicular carcinoma was split into two tumor types. Hürthle cell carcinoma and Hürthle cell adenoma, which is benign counterpart or precursor for carcinoma, which before 2017 were considered to be a subtype of follicular carcinoma, became a separate tumor type. It was recognized that their molecular genetics, their biological sort of underpinning is very different from follicular adenoma, and they became a separate tumor type. And also in 2017, the new entity, a borderline tumor called non-invasive follicular thyroid neoplasm with papillary-like nuclear features, very long term, but the short abbreviation is NIFP, was introduced with the idea that a number of papillary carcinomas previously diagnosed that are not invasive tumors, they are not really fully developed cancer, and they could be reclassified as these pre-cancer conditions. That also needs to be removed surgically, but it doesn't need to be further treated with radioactive iodine, for example. So this was the situation in 2017. And then last year, we had the fifth edition of the WHO classification out. So what happened? They reconfirmed these all tumor types that were defined in 2017, with the only difference that now Hürthle cell carcinomas were reclassified as oncocytic carcinoma. This is a pure nomenclature change. They just replaced Hürter cell with oncocytic. So don't be surprised if you suddenly stop seeing Hürter cell carcinoma in the scientific papers or presentations. I mean, instead, the term will be oncocytic carcinoma. But I want to stress again that nothing has changed in our understanding of the biology of these tumors, of the behavior, of the treatment. It's all the same. It just changed terminology from Hürter cell carcinoma to oncocytic carcinoma. I probably pause here for a quick second to see if there are any questions specifically for histology classification before we continue to maybe cytology and few words about the molecular test. So we'll continue. So we also sort of now touch on the diagnostic of cancer in thyroid nodules. So as you know, the cancer occurs typically in thyroid nodule, and at the stage of this patient, I mean, before getting the diagnosis, so obviously the question is sort of what is the best way to make the diagnosis, and what are the modern tools we have to make the diagnosis. And these modern tools generally include three sort of modalities. It's ultrasound, and with this time we're getting better and better ultrasound imaging that allow us really to predict preoperatively or without surgery how likely is that this nodule within the thyroid is actually cancerous. And then if there is a relatively high index of suspicion, we perform stick a needle, as you can know. This is a needle tracked into the nodule and collect cells for cytology. Okay. Cytology is a procedure when we look under microscope at individual cells or group of cells and make the diagnosis. And the third modality, diagnostic modality, a little bit more recent, and that's what we are going to talk a little bit, is molecular testing. Okay, so why we need molecular testing? Because cytology is very good in about 70% of cases. By cytology, about 70% of all the FNA cytologies come back as benign, and they have very low probability of cancer. And then about 2% come as malignant, and those are very high probability of cancer. Those patients definitely are candidates for surgery. But there is this intermediate group. I mean, but there's the 3, 4, and 5. But the way we also went through a new classification, a little bit of a new edition of the classification of reported thyroid cytology, not a big change, rather minimal. It was ATP of undetermined significance / follicular lesion of undetermined significance. Now it's just AUS, ATP of undetermined significance. But as the 3, 4, and 5, this has not changed. So this indeterminate cytology nodule, this is exactly the group, because of the probability of cancer in this nodule is not very, is not either very low or very high, like in benign or malignant cytology. As a result, that's where the molecular testing plays the biggest role in helping to predict if this nodules are benign or not, if this nodules are malignant. So I just jump from one to another.
Dr. Nikiforov, we actually do have a question. Can you clarify again what NIFTP means and IFTP is in the terminology? And would follicular variant papillary thyroid carcinoma be in that category?
So that's a very good question. So NIFTP is considered to be a pre-cancer lesion. I can tell you that in general, maybe I don't know to what extent I should complicate this, but let me just show this diagram. So there are 3 main pathways or ways how thyroid cancer develops. Okay, One pathway is when cancer develops driven by BRAF mutation. These cells become cancerous from very, very early stage. So this is just a cartoon diagram of just basically one follicle that is already cancer. Okay, this typically histologically we call microcarcinoma. Okay, and they can then grow, become the larger cancer, and so on and so forth. But many types of thyroid cancer don't develop from the very early stages from a single cell, already cancer. Those tumors are driven by RAS-like mutations and copy number alterations. These tumors typically start because the oncogenic stimulus is much weaker. So these tumors start as benign and it grow. It's a process. Imagine that we can, yes, a tumor go 10 stages, 10 steps from the benign malignant. For stage 1, 2, it's clearly benign nodule. For stage 10, it's clearly malignant invasive nodule. Okay, but this is a stepwise process. It's common not only in thyroid. It just came to this concept more recently. Anyway, NIFT-P is somewhere your stages 5, 6, 7. So this is a tumor that is walking from benign to malignant. It grew first as a benign nodule, but then it starts transforming to cancer. And at that stage, when we remove it, it says that it's not a complete cancer, but this is something that could potentially become completely cancerous if we wait for a longer period of time. For that reason, again, NIFT-P, if correctly diagnosed, is a pre-cancer tumor that historically, before 2016, 2017, it indeed was called encapsulated, non-invasive, follicular variant of papillary carcinoma. Many of these tumors are now reclassified or classified as precursor, borderline NIFT-P tumor. Okay. And I want to finally to finish with this. So there is still a small proportion of encapsulated follicular variants of papillary carcinomas that have to be called cancers because they are more advanced stage. But many of them now can be called and are called pre-cancer or NIFT-P. I hope I answered your question.
Dr. Nikiforov, I actually have a question. If I'm looking at this graphic, does this mean that it's impossible to get poorly differentiated carcinoma or anaplastic thyroid cancer unless you have some sort of mutation or copy number alterations?
You are asking extremely important and actually challenging, scientifically challenging question. The honest answer on the question is that we do not know for sure. But I can tell you what we know. We know that about 80% of thyroid fully differentiated and anaplastic carcinomas develop from pre-existing well-differentiated cancer. At least 80%. Whether we have a different pathway when this happened so-called de novo without stage of well-differentiated cancer, we are not sure. I can tell you data that exists, some data that we generated in my research laboratory suggest that such pathway do exist. But this pathway is not very often, not very common, and still most of them develop from pre-existing well-differentiated cancer.
So what is it that changes in the well-differentiated thyroid cancer? You know, I started out with well-differentiated thyroid cancer. What makes that change into either poorly differentiated or anaplastic?
It's a very good question. Typically, well-differentiated, let's talk about well-differentiated papillary carcinoma, okay, BRAF-like or RAS-like. If this tumor have only BRAF mutation or only RAS mutation, there is extremely low proportion, there is probability that they will go to poorly differentiated anaplastic carcinoma. But we have some of these tumors that already have more than one mutation. Thyroid in general is a very good model not model, but very good illustration of multi-step cancer progression. Cancer progresses through consecutive acquisition of different molecular genetic alterations and then pathological process of the differentiation. So again, BRAF V600E only papillary carcinomas extremely rare would go to poorly differentiated. But some of these tumors, small proportion, less than 10%, will have BRAF and third mutation, BRAF and P53 mutation, or BRAF and AKT1 or PIK3CA. This second hits that pushes the cells to the differentiation. And then when we look for well-differentiated cancers, 95% or 90% of them are either only BRAF mutation, or only RAS mutation, or only copy number alteration. When we look at poorly differentiated cancer, 95% of them BRAF plus TER, RAS plus TER, copy number changes plus P53. So they have additional molecular hits that push them to the differentiation. But I bring another level of complexity because you asked me before, do we think that anaplastic and poorly differentiated carcinoma can develop without pre-existing stage of well-differentiated cancer? And now I'm going to talk to you about the research hypothesis. This is a hypothesis that we are trying to test in the research lab, and actually very difficult to get funding on it. So we say that, okay, well-differentiated cancer develops through BRAF, then this is, we call it early hit. This is the early hit. And then later, some of the cells also acquire TER or P53. And then it was first well-differentiated, then with these additional mutations go to poorly differentiated, and then anaplastic carcinoma. And then the question is, very rarely, but once in a while, we see thyroid nodules that have only TER or only P53 mutation, without early hits BRAF or RAS mutation. And they look histologically like a benign nodule. And our hypothesis is that these benign nodules, they are not cancers, but they already have a late hit, and call it reverse carcinogenesis. And even these cells, God forbid, that then develop another early mutation in reverse order. These cells may go to anaplastic carcinoma bypassing stage of well-differentiated cancer. Therefore, we believe that nodules that have TERT only or P53 only mutations, even if they're benign, has to be removed, because this is like a reservoir. This is like a precursor for what can be very fast developing of anaplastic carcinoma.
Thank you. It's so fascinating.
Okay, we will continue. So we discussed about the molecular testing for cytology. Okay, and we discussed also that the cytology, if cytology has benign, can be benign, and those patients very unlikely have cancer and can be followed. It can be overtly malignant, and these patients go for surgery. And then we discussed that Bethesda 3, 4, and 5 have this so-called indeterminate cytology. And those historically were undergoing diagnostic surgery. And molecular tests were introduced specifically for this indeterminate cytology to help separate these nodules into likely benign and likely malignant. And the most recent, newest versions of molecular tests, they went even a step further, and they not only predict if it's likely benign or likely malignant, it's predict if it's likely benign low risk, likely malignant, sorry, low risk, likely malignant high risk. And we just touched on this. If, for example, in the PNA cytology, we find RAS only, we know that this will be a tumor, it will be a low risk tumor. If this is tumor that has BRAF clustered or RAS clustered, it's likely to have a high risk behavior, and therefore this tumor needs to be treated more aggressively. And finally, I just want to tell you that this is a very nice review published in 2019, excuse me, by Dr. Mason and Hagen. They are both endocrinologists, very well-known national leaders in thyroid endocrinology from Denver, University of Colorado. Sorry, let me just grab something. Some water. They published this review where they, in a very nice way, summarize the progress with development of molecular tests. So there was a first generation of molecular tests that were sort of, very limited, rather limited clinical use. Then we went through the second generation of molecular tests that had much higher sensitivity and specificity. And finally, we are now at the third generation of molecular tests that have rather high sensitivity and specificity and positive and negative predictive value. And this test help us to profile nodules and again predict if this thyroid nodule is more likely to be benign and can be watchfully observed, or it is more likely to be malignant and therefore needs to be treated. And plus, again, if this has a low risk or high risk molecular screen. And I probably just jump and just discuss one more.
And we do have a question while you're jumping slides.
Sure, go ahead.
If a nodule has 25% chance of malignancy with 0 mutations and clear borders, no calcifications, what is the likelihood of becoming high risk?
Well, I would say that in a practical way, well, with no mutations, it's very difficult for me. This scenario kind of little bit unusual because I don't understand 25% probability of cancer is based on what? Because typically we give the probability of cancer based on molecular alteration. Some molecular alterations are associated with 99% probability of cancer, some associated with 30 or 40%, some with 50, some 80. So 25% of probability based on what? Based on what molecular alteration? If it's based on the clinical parameter, let's say ultrasound give you 25%. But molecular testing is negative completely, and this is a good test. This is a third generation of molecular testing. Then I would say that the chance of this nodule to become cancerous is low.
Thank you for that.
And then to finish the discussion of the molecular markers, we discussed, first of all, markers to use for diagnosing cancer and thyroid nodule. That's what we discussed. A second and now third generation of molecular markers. But also, currently, molecular markers are used very broadly in advanced thyroid cancer, predict therapeutic targets. I'm sure that there is a lot of discussions at this conference because this is now a very hot topic in thyroidology and thyroid oncology. Unfortunately, over the last 5-7 years, we have identified a number of very important therapeutic targets and drugs that help us to at least to partially control this cancer. And I'm sure that you know that there are V600E mutations in anaplastic carcinomas, in advanced cancer. It's really now the markers that we are looking for if we want to treat these patients with dabrafenib and trametinib. NCRK fusion now have excellent, very specific low toxicity inhibitors. RET fusions in medullary carcinoma, RET mutations in medullary carcinoma, RET fusions in papillary carcinoma also now have a therapeutic target. There are other some sort of not not really FDA approved for thyroid, but for other cancer types, let's say ALK fusions, that also can be offered in some cases. So this is if we talk about molecular testing for these therapeutic targets in advanced cancer, there is a multiple molecular tests. There are many academic institutions have their own molecular tests that test again for BRAF, NCRK fusions, RET mutations and fusions, ALK fusions. So this is a much broader variety of molecular tests that can be used for advanced thyroid cancer to predict. So that's pretty much all what I wanted to cover in terms of the background. Perhaps we can now talk about if you have any specific questions.
I'm curious about getting genetic or evaluation molecular markers on pathology specimens that are old, like 10 years or 15 years old, and you've subsequently developed later disease. Do you go with the primary pathology to evaluate for molecular markers, or do you go with a lymph node new FNA positive finding to see if there's a change in mutations?
This is also a very good and very important question. Yes, if we have a recurrence of the disease 5, 10, even 3 years later, that we absolutely prefer to go for the newly more recent disease in order to provide perform molecular tests, because we will see not only the early mutations, we will also see what happened in later, more recently developed, what developed in maybe a subclone of the tumor that eventually gave this recurrent or metastatic disease. But not in all cases this is possible. Unfortunately, there are some situations when the recurrence or metastatic foci are very difficult to reach in order to collect material for molecular testing. In this situation, as a sort of surrogate, so to speak, marker for the new disease, we still would test all the initially removed tumor, because we still believe that it is a very sensitive molecular analysis. We will see not only the early hits, but also the late hits that may be present in the subclones, but we still will be able to detect it in the primary tumor. Now, another question that probably is within the general, this question that you asked is, can we test, do we have abilities to test tumor tissue that is very old? And I can tell that in principle, in generally, yes. If the tumor was removed 10 years or less, the rate of success is very high. If the tumor was removed more than 10 years, then it depends on many situations. It depends how well, how it was stored. Was it too hot in the room where it's stored, because temperature leads to degradation of nucleic acids and so on and so forth. So this is less common, but in principle, still, even if it's 10 to 15 years, there is a very good chance that we would be able to provide molecular characterization of the tumor.
Okay, so my understanding of what you said is that if you take a later cancer recurrence, the chances are that that the mutations are additive. Whatever was in the primary will be there, plus whatever might be new. So you're always better taking the new cancer diagnosis.
If there is a tissue from a more recent tumor, absolutely 100%, it's an ideal specimen to do this test. And I want to say that if this is impossible to identify, there is still value in testing the initial tumor. the initially removed tumor.
Okay, and then the second part of this is how accurate is doing the analysis off of an FNA, of a needle aspiration versus an actual pathologic tissue?
So for therapeutics, to identify therapeutic markers,
Yeah, to look for molecular markers. Can you do that easily off of a fine needle aspiration?
the answer is typically yes. But I want to say that when we have a tissue, there are, I don't know, 50 labs in the country who can do tissue, because tissue is very common. These are labs that test all cancer types, including thyroid cancer. When you have thyroid FNAs, there is much fewer cells. So the number of labs will be much more limited. There will be very, very few of them that can do it because of the nature of the sample. But this is absolutely, in a good lab, absolutely can be done. Yes.
Thank you. We have more questions coming in from our virtual audience. So a friend of mine named Hugo, who spends a lot of time managing the subreddit called Thyroid Cancer, has a great question. And we see this a lot out when we're helping newly diagnosed. How should we explain mutations to the average recently diagnosed patient? We often meet people who get more worried after the diagnosis because they tested positive for something like, BRAF V600E, and then they're told that that might increase their risk of not responding to RAI. So how can we help those newly diagnosed people and explain this?
I'm saying that this is not a simple question. I would say I would explain it in that way. First of all, what are genetic mutations? Genetic mutations, it's not that this is something new that we didn't have them before. We have them all the time. We have them 20 years ago and 50 years ago. We just could not detect them. Now we can detect them. Okay. I would also say that, that patients need to talk to very good clinicians. And this, now patients are very educated. They go on internet and they read these papers. Please understand that self-education is very good, but you still should talk to your treating physicians who is expert in the area. Like I explained to you why. Unfortunately, this is not fault of patients. This is fault of us, of scientists. The literature is full of not very good papers, published in not very good journals. They draw very, very big conclusions with limited data. So if you go and read, if patients goes and read the literature on BRAF V600E mutation, then you find any kind of papers. There were early papers saying this is a gene associated with a high probability of death from cancer and so on and so forth. This is simply not true. If you look at the body of literature, this BRAF V600E is an intermediate risk for recurrence, intermediate risk between 5 and 10%. Okay, so this is not really complete. Yes, these tumors will be susceptible to lose thyroid differentiation earlier. Yes, but it's not something that extraordinary. This is not really something that you have to be afraid of, to more than just having a total cell variant of papillary carcinoma, for example. Again, I would say that do not trust everything, any paper that you read in the literature. Either try to read summaries that are written by people who really are expert in this area, or ask your physicians to explain you what is really the correct understanding of this genetics. This is a new thing, and with everything new, you know that there are swings in one way or another. If you talk to a good clinician, they will provide you and trust what they tell you. Because again, now we have more information, and this information, there is a lot of good thing from understanding molecular genetics. And we just don't need to react on single studies that exaggerate the probably harm or exaggerate the importance of one or another molecular alteration.
Excellent. Is there a molecular test available for tumors that are not accessible by fine needle aspiration? This particular person has some advanced cancer in the larynx.
Well, you're probably asking about so-called liquid biopsy or blood test. If you can take blood and extract cells from the blood and test those cells by molecular analysis. I want to say that this is a very new direction in molecular diagnostics. We do have there are several reference commercial laboratories who offer tests for so-called liquid biopsy. So they can take your blood, filter it, try to collect cells, and try to provide molecular profile of the tumor that is not accessible for testing. I want to say that we are at very early stages. Sometimes they work. So if they detect confidently mutation, that's probably believable. But if they don't, it doesn't mean that really this is a correct analysis. Basically, I want to say that still all attempts should be made to get a tissue diagnosis and on tissue to perform molecular analysis. This would be more accurate than trying to go through liquid biopsy.
That's a fascinating answer. Thank you. We have another question, which is really quite interesting. It says, why don't patients meet the pathologist who looks at the biopsy cells and the tissues removed from surgery, et cetera? Wouldn't that be useful, considering that it's the pathologist's findings that determines what will be recommended throughout the course of treatment?
So why patients don't meet pathologists? Look, I am a pathologist, and I can tell you, we call us an unknown specialty of physician, unknown. Because I can tell you, if somebody asks me, what is your, I know you ask him, I tell them I'm a physician, they ask, what is your specialty? I say it's pathology. And I can tell you that unless, we are talking about the patient who had tissue diagnosis, they don't know. They ask usually, is it a speech pathology? So the only pathologies that are known to public is speech pathology. This is unfortunately, but that's how it is. I don't want to say anything better, about other clinicians, but that's how it occurs. You see that in reality, every diagnosis of cancer or many other diseases are made by pathologists. But then we provide this diagnosis to a clinician, to your treating physician, and they take the path report and they say that we made the diagnosis. So that basically, and only really very insightful patient can look at the report and see the signature of a physician at the bottom. That is how it has been. That's how a pattern of practice has been. And I can tell you, I don't want to judge if it's a good or bad, but I also want to say that in principle, you can request to discuss your pathology report with the pathologist who signs the case. It's not that somebody will prevent you from doing it. You absolutely have a right to do it. It's not a common practice because other reason why it is not a common practice, because probably it is general belief that your treating physician, let's say in this situation, endocrinologist or oncologist or endocrine surgeon, has more information than pathologists. They have pathology report, but they also have ultrasound, and they have CAT scans, and they have more information, and they probably can provide you with a more complete picture and treatment plan. But I want to stress again that if you want to talk to a pathologist, I don't think that anybody will tell you, no, you cannot do it.
So let me ask you, Dr. Nikiforov, from another perspective, since you are a pathologist, how often do you meet with the patients that you've done the pathology work on their tumors?
Very rare. Very rare. I mean, once per year, let me put it. There are some people who just write me emails and they're asking to talk and asking to discuss details, and that we do. I mean, but again, I want to say that maybe this is not necessary in most situations. If there is a you know, the standard case of papillary thyroid carcinoma, and we report that this is papillary carcinoma, tall cell variant. This is there are 18 lymph nodes studied, and 3 of them are positive, and 15 negative, and so on and so forth. I don't know if there is much more information that I will be able to offer to that patient. But if, for example, we have an opposite, we have a very rare case, very unusual case, very challenging case, that's probably when it would be more, I mean, helpful for the patient to have this discussion with the pathologist.
Well, Dr. Nikiforov, if you were my pathologist, I would want to meet with you. We have another question. It says, is it likely for another cancer to metastasize to the thyroid? And this person goes on to explain that they're a bile duct cancer survivor, and now they've got a nodule in the thyroid. And what are the odds of that happening?
I want to say again that I'm really, really impressed by the questions that you're asking today, because this question means that you really understand very deeply and very nuanced of the current situation. I can tell you that metastatic tumors to thyroid are exceedingly rare, but they definitely exist. Definitely exist. I can tell you that in terms of probability, and you probably will be surprised, most common metastases from other cancers to thyroid are from kidney, from renal cell carcinoma. And I can tell you, we run a very, very, very busy, very high volume molecular test lab, and we see maybe once per month, we do see a case where it's not thyroid, actually nodule. This is a metastatic renal cell carcinoma. We can now, with a very, very advanced molecular test, and we can detect it. Then the second most common now, there are like other cancers like breast cancer and lung cancer. But other cancers theoretically can metastasize to thyroid too. But I want to say that this is very, very rare.
So this person does go on a little bit with more detail. Would prior molecular testing of the bile duct tumor that they had and any blood, would that have any application towards the thyroid biopsy results?
100%. If you have a bile duct tumor that was profiled, and let's say, for the sake of argument, let's say that tumor had KRAS codon 12 mutation. And now this patient has a thyroid nodule. And the question is, if this is a thyroid nodule, most likely benign, and there should be no concern and no worries, or this is actually those extremely rare case of metastatic disease, there is very appropriate way to stick a needle in that nodule, collect cells, and test it molecularly, and be sure that the test that you order, that your physician order, has that gene mutation that was present in the bile duct tumor. Because if that mutation is not present in the thyroid nodule, or in opposite, it's different, that in bile duct it was KRAS codon 12, and you see BRAF V600E or RAS or P10, you know that there is extremely high chance that this is a totally separate lesions. Okay, so that's the reason why I think that molecular testing can be helpful in this situation.
So Dr. Nikiforov, believe it or not, we are at 49 minutes past the hour, and this runs until 50 minutes past the hour. So we are basically out of time. So I wanted to thank you so much on behalf of the people in the room who are all nodding their heads. And
Thank you for your attention and for very good questions.
I don't know if you heard that round of applause, but you just got a round of applause. And I will say to you, spasiba bolshoi.
Thank you. Bye.
Bye-bye. До свидания.